much, and thank you for the invitation to launch this workshop on a topic that I've been working on for the last 20 years, which is medication error prevention. Detecting the signals is one thing, but actually doing something about it is obviously much more relevant to patients. And I just wanted to start off by saying that medication errors occur frequently in all healthcare settings. As a practicing hospital pharmacist for about 25 years, I must have seen a medication error every day of my practice. I can't imagine a day would go by where I didn't see a prescribing error, a dispensing error, some form of administration error. And yet, when I talk to colleagues, medical staff, nursing staff, pharmacists, and say, did you ever have any training about when you encountered a medication error? And I ask them often to put their hands up. Perhaps I can try here. Who has had any training on medication errors in the room, if you're a healthcare professional? Well, few, because if you were any university to admit that any graduate from that university would ever make a medication error, what a condemnation of the educational process. So we were starting off on the wrong foot by expecting a perfection, 100% accuracy, 100% of the time from all our graduates. Even robots don't do that, and yet we're expecting healthcare professionals to do that. Now, the good thing is not all medication errors cause serious harm or death, or even have the potential to cause serious harm or death, but some do. And I'm going to start off the presentation by just some examples, some qualitative examples, some case studies, if you will, just to sort of get us our way into the thinking of what we're going to discuss for the next 2 days. This is Bailey Ratcliffe, a 5-year-old boy diagnosed with epilepsy at the age of 2 years on routine oral anticonvulsant therapy, but had to be admitted to a UK hospital because he was fitting. And the pediatric registrar prescribed intravenous phenytoin therapy, and there was confusion over the loading dose and the maintenance dose of phenytoin. It's, as you know, narrow therapeutic window, complex drug to dose and to prepare and administer. And after 2 hours therapy, poor Bailey received nearly 3,000 milligrams of phenytoin when he only needed 400 milligrams of phenytoin. And his heart stopped and he arrested and he died. Tragic. Let's get rid of the healthcare professionals. That obviously will stop the thing happening again. Well, unfortunately, it doesn't stop the thing happening again, because here is the case of Lucas Holschetter, a German-born baby, but the parents working in London. He too was prescribed intravenous phenytoin and was in this time prescribed the correct dose, but there was confusion because it was only intended to be administered over 1 hour. And he had that same loading dose over the next 4 or 5 hours. So he had 5 or 6 times the dose that he needed, and he too died. And actually, when we started to do some work in the National Patient Safety Agency and look at the world literature on loading doses, we could find nothing in the literature about loading doses and maintenance doses as a cause of harm for patients. And yet, any healthcare professional that has ever done any work with loading doses and maintenance dose knows that it's absolutely a risky business. And yet, there were no safeguards in place until we did some work on it in the National Patient Safety Agency. Here's a case of Ursula Sampson, an 86-year-old lady being treated for pneumonia in a high dependency unit. She was prescribed potassium chloride infusion for hyperkalemia. Now, we had done some work on this previously, and all the high-strength potassium was locked up in a separate cupboard, and you needed a separate register, so you couldn't get it mixed up with any other medicine. And 2 nurses checked the potassium chloride out of the cupboard and confirmed that this was the dose. And then a single nurse was left to go to the infusion pump and program in the dose that needed to be administered. And unfortunately, she programmed 100 mils an hour instead of 10 mils an hour, and the infusion pump administered the overdose and the patient died. And again, we're getting a number of these sort of potassium chloride too much, too fast types of infusion in the UK, even though we've done some previous work on preventing mix-ups with potassium chloride and sodium chloride. Here's Paul Richards and another patient, Singh Sunna. These were 35, 36-year-old gentlemen with leukemia being treated in a hematology ward. And this time there was some confusion over the formulation of amphotericin infusion for fungal infections that these patients had. And as you know, the traditional fungazone, 1 milligram per kilogram would be the dosage, whereas ambazone or abelset or some of the sort of liposomal presentations, the dosage may be 3 to 5 milligrams per kilogram. And in this case, there was a confusion. The doctor thought they were prescribing the ambazone or abelset, but the nurses used fungazone and overdosed the patient. And these two patients died on the same occasion. This is a case of a diabetic patient in the community this time, an 85-year-old lady, Margaret Thomas, with poor eyesight that needed a community nurse to come in and administer her dose of insulin for her. It was a new nurse who just recently came out of the hospital service, and she wasn't used or really had received any training on how to use the insulin pens. And so she needed to give the dose of insulin to the patient. And so eventually, after being unable to operate the pens, she took the cartridge of insulin out of the pen and tried to draw up the right dose in all that she had available. She didn't have an insulin syringe. She had an intravenous syringe. And so she tried to draw up the correct dose of insulin in an intravenous syringe and got units and mils confused, and administered 3.5 mils of insulin instead of 0.35 mils, and the patient died. And we've had similar situations where medical staff coming out of medical school didn't know how to administer insulin, and medical staff have overdosed and killed patients. Here's June Cutmore, a 71-year-old lady who was recovering from a heart valve replacement and coronary artery bypass operation with a known sensitivity to penicillin. Her notes were well marked that she had a penicillin allergy. She was wearing a red bracelet in the hospital, making it clear that she had a penicillin allergy. Unfortunately, the medical staff and the nursing staff didn't know that augmentin was a penicillin and administered augmentin to the patient, and the patient died. And then finally, two teenagers, both with leukemia, who needed intravenous doses of vincristine, and the doses were administered by the intrathecal route, and the patient died. And it's interesting to note that the EMA only last year issued some guidance on a new chemotherapy agent, bortezomib or Velcade, where 3 patients in Europe had died because the IV chemotherapy agent had been administered by the intrathecal route. And I could have given the other examples where epidural bupivacaine is given by the intravenous route and patients die, or oral antibiotics are drawn up in IV syringes and given intravenously rather than orally, or epidural feeds, or sorry, enteral feeds rather, are given intravenously because connectors connect together and allow administration by the wrong route. So clearly there are some examples of medication errors which patients read in the newspapers and scratch their heads and say, how can this be so? How can the same errors be repeated and repeated? And not just in the UK. If we look at this last error, the wrong dose by the wrong route, here are all the other examples of the same error occurring right around the world. And there must be factors which we can take on board in terms of delivery of healthcare, safe use of medicines, that you don't have to have a fatality in your own country, in your own hospital, in order to take the learning to introduce safer systems. And I've got to say, you know, not just put a warning in the SPC. That isn't going to be enough. We're going to have to do other things in order to minimize harms to patients. So the rest of my introduction is looking at medications, error prevention through the lens of patient safety. And what do I mean by patient safety? Well, patient safety is this sort of worldwide global phenomena that has occurred over the last 20 years, where, you know, suddenly it's dawned on healthcare providers that patient safety is the freedom from accidental injury in healthcare. And I fully acknowledge that pharmacovigilance was developed decades earlier after the thalidomide tragedy. And in a way, you were the first on the market in terms of patient safety. But in some ways, you're distant, you're separate from the patient safety movement that's been going on over the last 20 years. And I would really invite pharmacovigilance to get closer to, be part of the patient safety developments that have occurred in healthcare, and not just be over at the, at the sideline. And I think your change of definition is to be welcomed, where the previous definition for pharmacovigilance was to do with adverse drug reactions when medicines were given at the right dose and in the right way, and you're broadening that. I absolutely welcome that, because harms from medicine can be for a variety of reasons. And you can see, and this is coming from WHO work, patient safety improvements demand complex, system-wide effort involving a wide range of actions in performance improvement, environmental safety, risk management, including infection control, safe use of medicines, equipment safety, safety of clinical practice, and safe environment of care. And so all of that needs to be factored in when we're looking at long-lasting, sustained improvement in healthcare delivery. Here's just a little bit of data indicating to the WHO at the time, where in 2002 they made patient safety a very high priority for the World Health Organization, from this information which indicated up to 1 in 10 patients admitted to hospitals around the world were encountering avoidable harms, not just from medicine, but in general, avoidable harms. And this was the wake-up call to the healthcare providers around the world to say, we really must do better than this. And this is a famous slide that is often used here, indicating the types of activity and whether they would be considered ultra-safe and regulated or dangerous. And it puts healthcare in the same sort of category as mountain climbing and bungee jumping, indicating that perhaps there is room for improvement in terms of how we deliver healthcare and our thinking about errors of all types, and of course including medication errors. So a recent study published in the BMJ Quality and Safety Journal looked at 1,000 adults who were admitted in 2009 in the UK in 10 acute hospitals, and had a whole panel of physicians looking at medical notes and determining whether the deaths could have been prevented. And you can see, in this case, 5.2% of the deaths that could have been prevented. And the types of deaths we're talking about, well, poor clinical monitoring was considered 31% of the cases they observed. Diagnostic error were 30% of the errors that they observed. But drug and fluid management, 21% of the avoidable deaths related to drug and fluid management. So there's a whole lot to be done in a number of areas, and drug and fluid management is obviously one of those areas. So in the 55th World Health Assembly, you can see in May 2002, they wanted to bring the concerns over adverse events to the attention of all national authorities, and urged member states to pay the closest possible attention to patient safety and establish and strengthen systems for improving patient safety. And so I really invite the output from this couple of days, this workshop, to take this on board. And part of that is learning from the other safety critical industries. You know, the airline industry and nuclear power are often identified as areas where they've really had some good learning, and their industries are much safer now. And to minimize patient safety incidents, we should learn from these critical industries and target the underlying system failures rather than always the individuals concerned with the error. Let's have a look at the systems. And actually there's a whole science behind this, and human factors is something that we need to take on board. And here's just a quick graphic outlining why humans make mistakes, and there can be violations where people are routinely breaking the rules, but there can be mistakes relating to misuse or lack of knowledge about information, and then unintended actions, lapses and slips, where you have skill-based errors or attentional failures. And as I was coming into the building here, I always have trouble with the lifts or the elevators in the EMA. I don't know if any of you have similar problems, but I jump in the lift and I look to press the button and there are no buttons. And you have to go outside and find which floor you want to go on, and then you press the button and then it invites you to go into one of the lifts, okay? You have to be really very attentive. And I just wonder if this was a new medical product, how many of us today would have had an error relating to our patients, because I don't think I received any training as I came into the door as to how I was to use the lift system. I've been before, but I've forgotten. And this is a perfect example of human factors. And when we're introducing new products, be they medicines, be they new devices, what could go wrong in the real world, and how can we minimize the chances? And so here's the famous reason Swiss cheese model, where he indicates that there are barriers for making any type of error. But unfortunately, they're made of Swiss cheese. There are holes in these barriers, and sometimes these holes line up, and a serious error, in this case maybe harming a patient, may occur. And we need to replace the Swiss cheese with good old English cheddar cheese, which has no holes in it and actually is an effective barrier. Okay, well, here's something we could do within the regulation and labeling and packaging. I know we're going to talk about this later in the presentation, but this is something that we were involved in a few years ago. How could regulation enable medicines to have similar sounding names, to be packaged in virtually identical packaging, and then be surprised when it goes out on the market and 100 patients get the wrong vaccine in one clinic? And they just say, naughty healthcare professional. I remember phoning the company and saying, you're sending out identical packaged labeling. And they said, we'd just like to draw your attention to the extra line that we've added to the Repivax, that this is not identical. Well, yeah, but it's not effective. It may not be identical, but it's not effective. We can do better than that. We don't need to have these man traps, if you want, these error-likely situations where people can misselect. I really wanted just to quickly go over this diagram, which I think is after David Bates, a researcher in the US, who helped start to explain the nomenclature relating to medication errors and adverse drug events and adverse drug reactions. So there's a whole universe of medication errors out there. As I've indicated, if you're working in healthcare, you see errors every day. You cannot prevent all those errors, and in fact, many of them are not going to harm patients or even have the potential. So let's focus on the really important ones, and you can see the ones, adverse drug events, of which some are preventable and some are not preventable. And in fact, in order to make more effective use of pharmacovigilance, why not look at that whole circle at the top right-hand corner, rather than just the ones that didn't involve medication errors. And then, of course, you have the potential harms, the potential errors. So we like this very much as a demonstration of the different types. All medication errors can't harm you. There are some that can. Let's chase those. Well, let's getting into some of the numbers, because I was asked to help just set the day and look at the healthcare burden. And here's some, we've been very fortunate in recent years in the UK. We've had some very, very good research undertaken. And you can see Tony Avery and his group were commissioned by the General Medical Council in the UK to look at prescribing errors in community, and found that there were 1 in 20 errors in any of the prescriptions that were prescribed by general practitioners in the UK, 1 in 20. But only 1 in 500 were serious prescribing errors, which you might say, that's pretty good. But last year, 1 billion items were prescribed and dispensed in the UK. So that indicates 1.8 million serious prescribing errors in the community in the UK. If you look at dispensing errors, some research from Bryony Dean Franklin indicates dispensing errors. 1.7% of prescriptions may have a dispensing error, or 1.6% may have a labeling error, of which perhaps a third may have be described as serious errors. So there's another 10.9 million dispensing errors of consequence that were occurring in the community in the UK. And then looking at preventable medicines related to admissions to hospital, some work indicates 4.68% of emergency admissions are to do with preventable medicine-related events, and that is at least 250,000 admissions in hospitals in the UK. And so this information has been published quite recently and is helpful. Looking at the types of preventable ADE'S in ambulatory care causing patients to come into hospital, you can see the most frequent drug therapy problem, errors of omission were reported, and inadequate monitoring. And looking at the types of medicines that are involved in causing patients to be admitted, well, there were some that seemed to be the usual suspects that may be responsible for over half of all admissions. And they were non-steroidal anti-inflammatory drugs and antiplatelet drugs that that caused GI toxicity, which could have been prevented with additional measures. Lack of monitoring of diuretic or hypoglycemic agents, anticoagulant use. And so all of those are inadequately taken care of in our healthcare service in the UK. Does this differ very much from your experience in your countries? Error rates in hospital, again, we've had some excellent work indicating, looking at research studies between 1985 and 2007, prescribing errors in adults or children, and errors were common. Around 7% of medication orders had an error. And that would cause 2% of patient days. And then dispensing errors, again, you can see the rate there anywhere between 0.2 and 2.7 in hospital. And administration, more research is needed, but anything between 3 to 8% of the doses administered in hospital have an error attached to it. Now remember, I'm saying error, I'm not saying harm, but some of those errors could and do lead to patient harm. Okay, we'll jump over. In my own work in the National Patient Safety Agency, we have a reporting system for the National Health Service in the UK, and this system, all of the healthcare providers in primary care and secondary care have an opportunity to report. And you can see over a 6-year period between 2005 and 2010, we had over 5 million incidents. That's not just medicines, that's all the types of patient safety incidents that occur. Remember, there's lots of underreporting. This is 5 million and it's underreported, of which 500,000 were to do with involved medicines. And that was 11% of the total that was reported, with all the vagaries of reporting and you know, the chance that we only get a fraction of what's out there. And administration of medicines, because most of our reports come from hospital, administration of medicines was the top type of error, followed by prescribing and preparation and dispensing and monitoring. And of the types of error category, omitted and delayed medicine was #1. Omitted and delayed. Now, this is a challenge for pharmacovigilance. This is when a medicine is required and not given. Is that part of your business? It's part of my business from patient safety. If somebody has a heart valve and doesn't get their anticoagulant, that's really important. If somebody has septicemia and doesn't get their intravenous antibiotic, that's really important. If somebody is diabetic and is given a nil by mouth over the operative period and doesn't get insulin for 3 or 4 days and dies, that's really important. But is that part of your business, omitted and delayed medicine? Wrong dose, wrong medicine, wrong frequency, wrong quantity. You can see the sorts of numbers that we have there. So when we're describing what do we mean by medication error, we mean this. And what are the medicines most likely to be associated with serious harm? Opioids, antibiotics, warfarin, low molecular weight heparin, insulin, benzodiazepines, potassium. Oftentimes, the parenteral versions are the ones that cause the most harm. Injectable medicines are often associated with a lot of harm, not exclusively, but this is our findings over a 6-year period. And what do we do about it? Well, we put out guidance, but our guidance is very systems-based. We don't tell people, be more careful. We don't say, just have a little bit more education. It really requires a number of approaches in order to have a chance of making a substantial inroad into the harm. And so you can see here some of the promoting safe use of injectable medicines, actions that make anticoagulant therapy safer, promoting safer measurement and administration of liquid medicines, safer spinal and epidural, often working with companies for new products, actually identifying a risk and saying what we have at the moment simply isn't safe enough. The formulation is unsafe. The way that we administer the medicine is unsafe. We cannot just say to healthcare providers, be more careful. They're being as careful as they can, but making errors is part of the human condition. We need to be aware of that and actually engineer that, the prevention measures in. So there's just some ideas designed for patient safety. You know, we came up with some ideas about labeling and packaging of injectable medicines, and indeed on-screen display. What impact do we have on the electronic systems that healthcare providers have for prescribing and dispensing and administering medicines? Should pharmacovigilance in the future be as concerned about giving that sort of information to those types of provider as you have been with the pharmaceutical manufacturing? Is there a criticism that pharmacovigilance has been too concerned with the product and not enough concerned with the practice? Well, you've heard about the study, the project that we've had as a WHO project looking at involving pharmacovigilance centers in reporting and learning of medication errors. And I'm very indebted to colleagues in the Moroccan Pharmacovigilance Center who looked at their national pharmacovigilance database and looked at their incident reports to try to identify those that were preventable, and found 14% of those ADR'S were preventable. And they weren't even advertising that they wanted medication errors. Quite the reverse. They're saying it's a standard ADR reporting system, but they looked into their database and they found 14%. And with 10 other pharmacovigilance centers, we've got them to do the same exercise. And figures of up to 20% in ADR databases of preventable incidents, which in my category makes them medication errors. So that was very interesting. And so the project working on that basis has worked with pharmacovigilance centers to try to work out the differences that we have in patient safety and pharmacovigilance on terminology. The philosophy that we have that's slightly different in terms of the wider perspective that we have in patient safety. And tomorrow I've got an opportunity to take you through what we understand as root cause analysis and this broader appreciation of why things go wrong, why people don't follow standard operating procedures, why people don't follow SPCs. What can we do to make the practice safer rather than just say bad practitioner? This is an extract from the WHO report that was in draft form at the end of last year, and we hope to publish the summer this year, which shows you how we have to collaborate between patients and healthcare professionals, between pharmacovigilance centers, patient safety organizations, the industry, consumers. We can only do this together by discussing this, by understanding human factors, the importance of design. And and take some action together to improve this. So my final slide, and I hope I'll start a trend, and I'll finish before my time, okay? I hope we can do this, maybe even some questions. But here's some observations from me, how EU pharmacovigilance systems might help. We need a broader view of patient safety. This is more than the product, okay? This will require a greater understanding by you all of systems of use, how things actually occur outside of randomized controlled trials. That's not the real world. What happens in practice when medicines are prescribed, prepared, dispensed, administered? A link to the use of medical devices to prescribe, prepare, and administer medicines. So this is a much broader view that I know you're to do with medicines regulation, but actually many times you cannot administer the medicine without a device. We need the cross-cutting approach with medical devices, and I'm using a broader view about devices, including electronic systems for prescribing, dispensing, administering. So, you know, the way that you select your medicine, if a new medicine is introduced and it comes at the top of the picking list, and maybe it's the new strength, it's one that looks very similar to a previous one, or the computer system only gives you 20 characters to describe the name of the medicine, and the name of the medicine to describe it safely needs 30 characters. How are you going to deal with that? Broader and new categories and methods for reporting and learning. I think that one of the very interesting things we've done on our project is look at the WHOART system and the MEDRA system and look at the categories you have there, and are they fit for purpose for medication errors? And I think that there needs to be some additional categories in WHOART, in MEDRA, to enable you to categorize and describe medication errors more effectively. And I think that you'll understand from tomorrow the WHO has a classification system for patient safety. And I think the patient safety system can benefit from some categories and some classification from MEDRA and WHOART. So there could be real cross communication on classification systems. We need new methods to identify, communicate risks and solutions, and implement and sustain safer practice. So this is much, much more than spotting signals. Oftentimes we know only too well what the signal is, but how do we do something in practice that can be implemented and sustained and actually impact on patient safety? So it's more than signal detection. I might say that we need better design of names, labeling and packaging. You would expect me to say that. I think there's better use of risk management plans in the EU. I mean, this was a great idea, but when I look at risk management plans, very seldom do I see anything which addresses my needs from patient safety about how medicines are prescribed, dispensed, administered, and monitored. There's a lot about ADR detection, but not a lot about, well, how could this go wrong? How can we minimize the potential risk? So much greater use of risk management plans for medication error prevention. And better use of technology. I've indicated e-prescribing and e-systems for dispensing and administration. I just wanted to finish on one last point, which is the use of barcodes. I know there's been discussions and consultation recently about anti-counterfeiting measures and the use of barcodes for anti-counterfeiting. And this exactly shows you that we haven't got the right idea yet, because if I showed you those dispensing error statistics, it's clear that we can do a whole lot more to improve the accuracy of dispensing. Yet EU proposals for the use of barcoding was only on anti-counterfeiting for a few high-value medicines. We've had barcoding on our medicines in the UK for 10, 20 years, but if you go into a community pharmacy in the UK, nobody is using those barcodes. So regulators said, well, barcodes is quite a good idea. Industry did it. And then practitioners aren't using barcodes for patient safety. And all we're talking about is introducing yet more barcodes for anti-counterfeiting. And is that measure too going to be, you know, industry is going to spend a lot of money doing that, and then nobody uses it in practice? It's a complete waste of time. So we need to talk to people, one another. What can we do together to actually benefit patient safety? So thank you very much. I hope that starts the session off, and I look forward for the debate for the rest of the 2 days. Thank you.
I love the concept of making errors as part of the human condition, because it's so true, isn't it? Given that we finished slightly early with the presentation, and thank you for being succinct and extremely topical and extremely informed, let's take 5 minutes, if people would like it, either to ask questions or to raise points, which might then feed in and enrich the discussions that come further. Is there anybody who would like to make an intervention? If you do, please identify yourself and then put your case. Please, over to you.
My name is Françoise Charmaisonnec. I'm nurse, and I'm the vice president of ESNO, which is the European Specialist Nurse Organization. And I agree completely. I'm very happy about this presentation. Thank you very much. And as you said, error. I mean, the zero risk is not realistic, but we have to do the best to avoid medication errors. And we have seen that a lot of errors are due to dispensation, and nurses are dispensing the medication, are monitoring the medication. And I don't want to defend nurses. I mean, we are doing errors, that's true, but we are a part of the chain. And I must say that the regulations that the European Commission doesn't support very much what is happening nowadays regarding nurses. We know there are studies showing that the bachelor level for nurses increase patient safety. And the new directives, which was voted end of January, the Commission proposed a 12 years prerequisite before the nursing education. There was an amendment proposing 10 years, and the deputies voted for the amendment. That means that in Europe, there are not really a coherence and to ensure, I mean, to do the job, to ensure the quality of care and safety. Moreover, regarding the mobility of the workers within Europe, and regarding the shortage of nurses. So we may have foreign nurses working in a country and not trained and doing their job as nurse and dispensing medicine. That's a point I wanted to raise and to think that there is a lot to do, and also in terms of training and in terms to find how can we do that the tasks in the daily practice are not interrupted, which happens very often. Thank you.
Very interesting intervention, and thank you for that. And I think your intervention will start some of the themes that may run through our meeting, and that is very much about the role of the different key actors in healthcare delivery, and that each actor has a critical role and needs to have the relevant information, training, and so on. And your comments on the, I guess it was the healthcare directive, across cross-border healthcare directive you're making reference to. It was more a point than a question. Is there anything you're okay? Please, would you like to introduce yourself and then make your point or question?
Jurate Shversati from PGU, representing community pharmacists at this instance. I just want to react on the use of the barcodes, and I think you are making reference to the Falsified Medicines Directive, which was approved. And I'm happy to tell you that actually there is a provision in the directive which allows to use the serialization and this system, which will be put in place very soon for pharmacovigilance purposes as well. So it's already in the directive. Then how we are going to see it being implemented or used by the national governments or by the European Commission, we shall see. But I want to bring to your attention an example which actually nicely fits in what you have called for. In Belgium, the Community Pharmacy Association came up with a project of actually serialization using linear barcodes of the medicines for the purpose of authentication. And when they were putting it in place, they realized that it can be extended. So basically what they are using for is for opportunity, which is at the moment of dispensing when you have a patient in front of you, and using the barcodes for actually displaying the messages that are related to the dispensing product and the patient that you have in front of you. So they are having this system and it's working quite well. Everyone is very happy, and it has been used for messages on not only on the recalls of the products, but also of delivering messages of, let's say, remind the patient not to take leftovers of antibiotics and those sort of things. So it's already have been, let's say, piloted.
I just react to that. I won't be happy until every community pharmacy in Europe is using the barcodes on the medicine as part of the dispensing process, and we're far from that at the moment, and I think decades away, because I don't think national inaction is going to enable that. And equally, when nursing staff are administering medicines, going to the previous speaker, they should have the benefit of using barcodes. And as I go around the world, and I was in Singapore recently, you know, the developing world is overtaking Europe in terms of medication safety initiatives. And we're still talking about it, and they've got it in practice for 5 or 10 years. So the challenge is, I'm not interested in looking at a pilot in any country. I want it as standard, so that I go to a supermarket elsewhere in Europe, and they use the barcodes to charge me on the till. But if I go to the pharmacy that may be based in that supermarket, they won't be using the barcodes to keep me safe as a patient, and that is unacceptable.
Please, sir, introduce yourself.
Okay, Daniel Grant. I'm a physician, so I'm the one who's making the mistakes that you try to prevent. And I'm a member of the Drug Commission of the German Medical Association, and also I've been a member of the WHO expert group for priority setting and research on patient safety. And I want to thank you for your excellent talk. And I think you've stressed the point that we have to have a systematic approach, and we have to look at the process of using medicines if we want to prevent medication errors. And I think I would like to add that definitely the prescription errors are the ones that we have to focus on. But it's not only that the single physician makes the mistake, but also that even if it's always or often physicians don't communicate, and then they don't work well enough together. So even if the physician makes a correct prescription, there can be an error that occurs because there are other physicians that make also correct prescriptions, but that interact with each other. So I think if we want to improve medication safety, we have to look at the coordination of care, and that's a very big problem that you don't see if you just look at this, the single prescription.
Thanks very much. Should we take a last point, please, on the left-hand side there?
Thank you. My name is Anne-Marie Hellebeck. I come from the Danish Society for Patient Safety, and I'm also a member of the EMA name-related group. Thank you, David, for a wonderful presentation, and I can confirm that all the patterns and rates, we see the same in Denmark, and I think in most countries, and also the case stories, I could remember individual patient stories in exactly the same situations. But there was one category I was missing, and that is run out of stock. in Denmark, we recently have seen quite a few serious medication errors caused by running out of stock. That is, that we don't have the medication that we used to have, that we're used to, and then we get something else, bit different strengths, bit different name, and it may look very much like another medication. So we may have visual mix-ups, we may have mix-ups of strengths, we may have mix-ups of lines in the electronic ordering system. And I just wonder if you see the same pattern in the UK, David.
Oh, not just the UK, worldwide. Medicine shortages, just in time, is a wonderful concept, isn't it, when it works? But if you have no stock, if essentially companies are manufacturing to before, you know, on an order, there is no buffer stock, and often you have one factory in the whole world making something. And if that factory has a difficulty in production, then you're going to have a problem. And so this is a problem worldwide. Medicine shortages, complicated manufacturing and logistics, supply chain, something that we need to address. And it was incorporated in my omitted and delayed medicines. That is a factor, not the only factor by a long shot, but it is a factor and in a growing factor, particularly for medicines that are generic, are not very profitable. Industry would like to get rid of them altogether, really, and yet you still need them to treat your patients. Thank you.
Colleagues, just in the interest of time, I won't repeat the concluding slide that David presented, but some interesting points coming out of the discussion. The key role of different healthcare delivery actors, nurses, pharmacists, doctors, etc. A particularly interesting point that we may explore later in the meeting, and let's be ambitious at this early stage in terms of barcoding and use of technology as an opportunity for patient safety. The critical importance of communication within the healthcare team, and maybe you could extend that beyond the individual healthcare team actually to the different actors that are implicated in the wider healthcare delivery system. And finally, and something I'd never thought of before as a potential cause of a medication error, product shortages out of stock, as you put it. Very interesting observation. I suggest we move straight on then.